Okay, our next speaker is Charlie Brannis, and he's Associate Professor of Epi at Penn, and he's the director there of the Cartographic Modeling Lab. So,
just promoted to full professor.
Just promoted to full, okay.
Thanks. Wow. Appreciate that.
Here, a round of applause for that promotion.
It's the last time I whisper that to you, Al. Thanks so much. I appreciate it. Thanks for inviting me to talk. I really have enjoyed these presentations this morning, from the PROs on to the Z-bias and then the last one with the network analysis. It's just fascinating stuff. I want to take us in a little bit of a different direction. As was said, I'm the director of Penn's Cartographic Modeling Laboratory, which is sort of the place for geography at the University of Pennsylvania, since we don't have a department of geography. The Cartographic Modeling Lab is a joint venture at Penn between the School of Medicine, notably, but also between the School of Social Policy and Practice and the School of Design, where the architects and the urban planners sit. And so we're very interested in place and the implications of place on all manner of different things, and I would say the balance of our portfolio is really on health and medicine. And we're constantly trying to, and we're, I think, succeeding in making our medical and clinical epidemiology colleagues geographically literate. So one of the things that we've been doing over the past few years is really using a branch of geography called location science. Geography basically, as someone was talking to me about GIS this morning, GIS is one major component of geography. It is essentially cartography or map making. There's also spatial statistics, which some of you may be familiar with. But then there's a non-statistical side of geography called location science or classical spatial analysis, which is essentially a deterministic, non-stochastic approach to making decisions about space. And some of the questions that come up, and these are very much applicable to healthcare and have been used in many different industries, is about where facilities should be sited. Where should the next healthcare facility be sited? How many of these facilities should we have? How large should the facilities be? And how should demand for the facility services be allocated? These location allocation or classical spatial analysis problems are solved using a variety of different optimization methods. Linear programming is the most common, although it's frequently not successful. Excuse me. But we use something more frequently called integer programming, where we deal with facilities as whole numbers. Obviously, citing 4 1/4 hospitals is not applicable in the real world, or 3 1/2 ambulances. So we use them in whole numbers. This adds a whole other level of complexity to trying to solve these things. When you force it you don't permit fractions in it. There are various optimization algorithms. The simplex algorithm is obviously the most famous. If any of you are familiar with it, it's considered one of the great mathematical achievements of the 20th century. And then branch and bound. And then we also use a number of heuristics, and I'll show you some of these briefly. The heuristics that we use, because many of these models become so large, the number of options to sift through becomes so big that even the biggest supercomputer or the cloud can't solve it. And so we use a number of heuristics which find near optimal solutions. And I'll also add, for those of you who use AHRQ, AHRQ is the Microsoft of geographic software. AHRQ has a new addition to it on the Network Analyst location allocation extension that will do some of these heuristics for you, and so that you can actually make decisions about location of facilities in real time. Now it's actually quite accessible to anybody. The one particular example I want to tell you about is one that we've been working on for over a decade now, and that is the trauma resource allocation model for ambulances and hospitals. And I know I was invited to give a talk, so this is a CER audience. I want to tell you first about the effectiveness and then really deal more in the comparative side of this. Effectiveness here has essentially already been established, and the first thing to understand is what I'm about to show you is the given here is that trauma is a, quote, surgical disease. That is, if you are shot by a gun or you are run over by a car right out here, the only way, if you're severely injured from that, which oftentimes you will be, the only way to definitively treat that is to get you to an operating room. There's actually very little that can be done for you in the field for severe trauma. And so time becomes a major component of this, and in that, time and distance are interrelated, so that's where we come in as geographers to begin to assist in these decisions. Now, there are two major studies. There have been several others as well. Actually, one of them is from the NSCOT study, which someone out here has on a poster from Johns Hopkins. Ellen McKenzie had done that. There's a nationwide study of 15,000 trauma patients, which showed that trauma centers and trauma center care was a significant impact on mortality by about 25%. And trauma centers are distinguished from any hospital. Okay, they are specialty hospitals, so that a severely injured patient, the thinking is, in triage in the field for EMS and ambulance providers and so forth, is that you would bypass the nearest hospital to get to a trauma center. And there's also another study recently in JAMA on the mortality benefits of being transported by a helicopter. So what we've done is we calculated these axes historically. We looked at this as driving axis for the state of Pennsylvania, and this is what people typically did. They said, here are the trauma centers with the black dots. How fast can we drive to those trauma centers? Well, that's not entirely meaningful, because you have to consider that people can either drive or fly, and there are other different geographic metrics to doing this. So if you overlay onto this map the helicopter locations, the stars here, and you make some consideration about how the helicopters and the trauma centers pair with one another, okay, you get a different sense of coverage. The coverage changes dramatically, and as you either cite these helicopters and trauma centers as same-site pairings, I think it's better if I just do it here, you make a perfect circle, or if you offset them, you begin to geometrically bow down that circle into various ellipses. And this coverage allows you to better, when you think about it, allows you to better match the supply of medical care with the demand for medical care, meaning the severely injured people over that space. And also, there's some coverage from New York State, so you can also bring in spillover coverage from the neighboring state. I won't get into how this works necessarily. But what I will say is that we found some from the traditional method. So this is one example from the state of North Carolina. The Office of Emergency Medical Services did this map of basically putting circles or bandwidths around their helicopters. And they concluded they were very concerned about covering 95, which is a highway that runs right down the eastern corner of the state. Let's see if I can get that right here. So this is 95. Their coverage concludes that 95 is covered a great deal by the system, but in fact, if you do it the way we've done it, which we think is a bit more accurate, you find that this helicopter has nowhere to really fly internal to the state of North Carolina to match up with the trauma center, and this lower portion of 95 is actually uncovered. And we've gone ahead and done this for the entire United States, where we have both driving and flying calculated out, and we've been doing this each year for a good 5 or 6 years now, and in fact posting it online at a website that has been supported by AHRQ, but also by the CDC. This website is traumamaps.org. I would encourage all of you to visit it. We have both a high-resolution version, and for those of you, as soon as Apple can get its act together, for those of you that don't have flash-enabled phone, you can also go to our low-resolution for devices that aren't flash-enabled. And this will let you fly in. You can do the same thing in terms of mapping it for the entire United States, or you can fly into any state, map where the trauma centers are by level, and map all the other hospitals in the United States as well as the base helipads. Zoom in, take a look at those, make some comparisons about decisions about who is a trauma center, who might be a trauma center in terms of doing some comparative simulation and changing the system. And there's various other components of this. I won't get into it. We've added a lot of tools to this where you can identify the hospitals, click on them, put a satellite image, determine how many beds, basic components of every hospital in the United States, including its trauma center capabilities. And I would encourage all of you to go explore the website. The website itself and the metrics annually have been picked up by Healthy People 2020. So now these are benchmarks in terms of getting access to trauma centers in the United States for the country that we will continue to update, possibly yearly, but probably more every 5 to 10 years. We've had some coverage in the news. Interestingly, it's amazing, any little bit mentioned on CNN has an amazing impact on people's use of and notice of what you do. This is when actress Natasha Richardson had passed away in a skiing accident. At the very end of this article by CNN, they mentioned the website and put the link on there. This is before we were on the cloud. Our visits went over 1 million visits in 24 hours and crashed our server, and resulted in a lot of nasty emails directly to me, like, you guys said this worked. and we can't look at where our trauma centers are, sudden interest in that. Time Magazine has covered this. This was interesting. We've been trying to make the case for more rural coverage, and part of doing that is making the case to people who have immense access to trauma centers. For instance, in the state of New Jersey, the average New Jerseyan has access to 21 trauma centers, comparable to maybe in the state of Nevada or other western states. So we've been making this argument about where you vacation and what's the coverage where you vacation. And then my personal favorite is Hell for Leather Magazine covered us for their motorcycle lobby, and so we got a little bit of good. And they very much enjoyed the website as well. So, well, the question became then, well, so what? Who cares? You've showed us where the existing centers are, but what about the comparative nature of this? So where are the trauma centers located? Where should the trauma centers be located? Or where could the helicopter depots be located? And I want to add in helicopter depots. I don't want you to forget about this because trauma centers it's quite challenging. And when we say where could trauma centers be located, I'm not really suggesting that a trauma center be built, new bricks and mortar out of thin air. But the decision for any state about which hospital that is currently not a trauma center to be designated as a trauma center is actually quite a political and important process. So that's really what I'm talking about. But helicopters are actually quite mobile. Helicopter-based helipads are actually quite mobile and can be put just about anywhere. So there's a lot of opportunity here, and policymakers are constantly making these decisions, and we wanted to provide them with some support. Now, just like the prior speaker, I don't want to get into all the details of this, but there is an optimization model that underlies this. Basically, this is taking the entire United States, taking all the demand within block groups. And demand here, by the way, is not, we're not talking about the demand of injured people, not a direct measure of medical demand, but a measure of the population, because we think anyone is at risk of being injured. And so we want to give access to the general population. So we're trying to figure out where the population in the 200,000, where's the population in roughly the 200,000 block groups in the U.S., and which one of them are covered. And so we multiply these two, and I can go into the details, and there's various constraints that come in it. As an example, let me show you the state of Maryland, which had, this is actual coverage of demand in zip codes, not block groups in the state of Maryland. And in fact, there's very little difference in the results, whether you use actual population or severely injured people, actual medical demand. So the existing coverage for the state in 45 minutes was about 95% of the severely injured people in the state had access within an hour. We did this model where we picked up all the resources in the state, and we optimally relocated them. In this case, we're able to generate the same coverage with only a single trauma center as opposed to 8 trauma centers, and with 6 helicopter depots, the ADs as aeromedical depots, as opposed to the 8 that the state originally had. And there was another reconfiguration where we took their existing resources and redistributed them optimally and got almost 100% coverage. And so that's 5% more coverage than what they existing had, and that's a lot. That's 500 severely injured people every year that could have access. And remember, these folks are folks that would otherwise die, we think, or would have a serious mortality risk in the absence of coverage. And there are many different other options. We built this trade-off curve. This is the existing system. These are the 2 examples I showed you. And everything to the upper left are all the other configurations and comparative configurations that could be chosen. But the question says, well, so what again? The policymakers came back to us, and as you can imagine, they didn't really like the simulation of completely redistributing all the facilities in their state. And the state of Maryland, I will say, in deference to them, is one of the oldest trauma systems in the country, a state trauma system, so quite venerable and obviously would not want that sort of input. But there are advantages here. There are many more choices than can be made by any human planner. But the policymakers aren't interested, so what we really started thinking about more were smaller scenarios that they could bite off and use in the real world. And these are the kind of scenarios that we had been asked to do anyways off the cuff, things like adding 2 trauma centers. So if I am doing a competition in my state, I know where all the hospitals are, I know who's potentially eligible to become a trauma center, but I only want to designate 2 of the 30 candidates as trauma centers. Which of the 2 would give me the most advantage? So you can see this is the state of Washington. The light blue is what they have now. If you added these two yellow trauma centers, you would get, that would be the optimal coverage to add on as much additional coverage, as possible. You could also do this with two helipads. This is the state of Pennsylvania. You could do it in combinations of these pretty simplistic comparative scenarios. Or you could do it even smaller, and this is actually much more common for us, is the choice of, well, I have one hospital that I'm considering as a trauma center. Should that be the one we choose, or is there a better option in the state for that one at a time scenario? And the same for adding helipads. And again, these can be put many different places. When I showed this particular map to the state of North Carolina, they were very enthusiastic, but then came back and said, this one optimal choice here for location of the helicopter is not exactly where we can put it. That's actually swampland right there. And that's very common, right? Because you can put a Kwanzaa hut and basically put a helipad just about anywhere. And we thought, we should make this much more interactive and give them more options. And a really brilliant doctoral student I said, look, why don't we do it, for instance, helipads can be anywhere. Let's do it for every small space across the state and give them a map that says, well, this yellow is the absolute best. You can imagine if you turn this three-dimensionally, this is like a mountain range where the highest peak is the yellow, but the darkest red is second, third, fourth best, right, and on down the line. So they give them a very large space from within which to choose where the best location for the next facility would be. The future here is for us, and is why AHRQ is funding us, is to think about other time-critical diseases. Stroke is the one that is coming to mind most, and what we're working on very closely right now. The stroke system in the United States is where the trauma system was 25 years ago, and in fact is looking to the trauma system and the way the trauma system developed, which was actually quite haphazard. And so the stroke system and stroke center designation, we're hoping to inform that with these sorts of models and maps. And we're also going to be doing this, the website I was showing you before, we're developing a technology where instead of asking us to run the scenario for you for the hospital you want to convert to a specialty hospital or the place you want to put a helicopter depot, we're developing a technology where you can do it interactively online by yourself. So you can say that X hospital, what if that hospital were converted into a stroke center? What would it change in terms of accessibility, geographic accessibility? And then we're also doing cost and outcome projections to accompany that given the known effectiveness we have for many of these different scenarios. And that's it. Thank you.
Thanks very much. And again, we'll hold questions till the end when I'll invite all four speakers up. Our fourth speaker is Jason Roy, who's at the University of Pennsylvania School of Medicine, Biostatistician, Department of Biostatistics there. He's done work on missing data and causal inference, especially in the context of dynamic treatment strategies. And he's talking to us today about a source of bias in case crossover studies.
Okay, thank you. And my abstract doesn't quite match the title because I was originally going to talk about matching with more than two groups, and then it turned out that I need about another month to have results. So because it's very slow to actually do matching with four groups if you want to do it optimally. So rather than show you partial results, I decided to present this topic, which is more complete. So. So this is work with some of my collaborators at Penn, and whose names you see there. So so we're looking at case crossover studies, and we wanted to explore what kind of bias would come from just people sort of naturally picking up diseases and picking up medications over time, because even if they're unrelated, people just pick up comorbidities and pick up medications over time. So that's the basic idea, is we want to see what happens there. So we'll sort of just quickly review what case crossover studies are and then get into sort of how we're going to explore this bias issue. So probably most of you are familiar with it, but the basic idea is you'll only look at cases, and and then you'll look at, so there'll be a time that of this index date, which is like the time that they were diagnosed with the disease or something, and then you'll look back a little bit to see if they had the exposure just prior to disease, and then you also look back even further to see if before that they had this exposure. So you sort of compare these exposure odds in these two time periods. And this is useful because you can control for sort of time independent, time invariant confounding. So you don't have to worry about time invariant factors because you have person serving as their own control. But the reason that we were especially interested in this particular problem is that typically in pharmacoepi studies, when people have done these case crossover studies, they always have the control period precede the sort of the exposure period for the case window, if you will, because you have this issue of the adverse event can affect future exposure. So rather than have periods of the control periods before and after disease, they typically just have it before. And so we wanted to see what kind of impact that might have. And I mentioned that there's a paper that reviewed sort of case-based kinds of studies by McClure and others that appeared in PDFs that's, I think, pretty interesting and summarizes a lot of these issues. So this is just it's sort of a diagram of what we're talking about, where you have index date, could be date of diagnosis, and then you'll have what I'm calling the case period, which is some period prior to the index date. It could even just be sort of right at the index date, or some period before that, where you're seeing if whether the person had the exposure, and then there might be a gap, and then you'll have some control period, and then you just sort of observe whether you sort of look for the exposure, and so you want to basically know if the exposure occurred more often here than it did here. Okay. So this can be useful when you're thinking about maybe this. I think, as Bruce mentioned, maybe this isn't quite worded right. We're thinking about transient kinds of exposures. Something that you might have every once in a while, antibiotics or something, and then we're thinking about it more like acute kinds of outcomes. So it wouldn't be as good for sort of chronic use of medications and chronic diseases so much. I mean, because you could imagine if somebody's, let's say you're talking about a medication that if you're on it for 10 years it causes cancer or something, that wouldn't be very useful here because you would just have long-term exposure and you wouldn't have any discordant pairs. So we really need discordant pairs, which would mean, like in this diagram, if you have exposure in both the control and case period, then that doesn't help us, or if you have exposure in either, it doesn't help us either. So we really want the exposure to be in one or the other if you want to have a lot of power and so on. Okay. So I mentioned this a little bit, but it controls for these fixed characteristics, things that don't change over time. But you're susceptible to bias if there's, time-varying confounding, time-dependent confounding, and so on. So you have this exposure period, you have this case period and this control period, and some things about the person might have changed, and that could be really what's causing the exposure odds to be higher in the case period or something. So this is well known that you have to assume that there's no exposure time trend and no carryover effects and things like that. But so as I mentioned, the reason what we were interested in was this issue of that people just tend to pick up diseases over time. So even if the drug's not causing disease, you're going to tend to have more medications over time and more diseases over time, and that's what happens. So you could imagine then if you have a case crossover trial where you always have the control period precede the case period, that you probably will see an association where that might not be causal. So we're interested in sort of exploring different scenarios and when would this be the kind of problem that we should really be worrying about. When should we worry about this? Okay, so the basic questions then involve so when would this cause enough bias where we're concerned? So we're going to look at the length of the control period. We're going to look at the incidence of disease, and we're also going to look at the incidence of exposure. So how quickly are sort of people naturally picking up this disease or naturally getting sort of more medications? And also, like, I think these time windows are what really could be important as far as if you have a control period that was if you have a long control period, a long sort of case period, then they're getting pretty far apart. And then if somebody's naturally picking up diseases and medications, then you could have more bias. So that was sort of our guess. But we wanted to quantify this. And this was this is from the Observational Medical Outcomes Partnership, where they looked at different methods. And so this was something I found online and a graph. But they used a bunch of different methods. And right here is the case crossover. And the reason I mentioned this is just because it showed a very high false positive rate compared to some of these other methods, high dimensional propensity score, and so on. So there's a whole bunch of methods they compared. And way out here is case crossover, where they have a high false positive rate. So we're thinking if the bias is in the direction that we think it would be, that might partially explain why we're getting false positives. So this is another reason we wanted to look at this. Okay, and I don't know if I should actually, I'm calling this a simulation study, but it's actually an asymptotic bias analysis. We also did are doing a simulation study, but all I'm presenting actually now is asymptotic bias. So you could think of it as simulation with large N, but either way. So, but all we're doing though is assuming that the true causal relationship between the medication and disease is null, and the odds ratio is 1. So there's really nothing going on. And then what we're going to do is we're going to simulate sort of disease using population rates for 3 different types of diseases, in a sense, so rare, moderately rare, and common diseases. So we want to look at sort of 3 sort of common situations. And we're going to vary this. We're going to vary the control period based on what we've seen in the literature, and we're also going to simulate exposure based on for 3 different types of drugs, basically. So whether they're common or rare, and so on. So and then we'll look at all these different combinations of rare exposure, rare outcome, and everything in between. So this is a partial review, a very sort of some examples of case crossover studies. There's a whole bunch more, but I just wanted to show you a few of them. So we looked at what do people usually do when they have these kinds of studies, these case crossover studies, and we wanted to look at in particular what do they use for these periods of observation where you're looking for the exposure. And so these are some of the examples, but you'll see that if you look at the control periods, for example, you'll see a lot of times that they end up being 60 days or less, in a lot of cases quite a bit less. There's one example here where it was where it was a year, but in a lot of cases it's 30. You'll see some 30 days, sometimes a week, and so on. So from what we've seen, it's common to be 6 months or less, and oftentimes more like 3 months or less. But these are just some examples. And so so day 0 was the index date, and negative means how much prior to that we're looking at. Okay. And so then we wanted to look at 3 different outcomes. So we're imagining we're basically generating outcomes for people based on what we know about these either rare outcomes or common outcomes. So for rare outcome, we chose sudden cardiac death. So we went to we found a paper that reported incidence for sudden cardiac death, and we're doing this by age. So we have these different age ranges, and then you'll see, people 25 to 34 years old, the incidence rate was 6 per 100,000. So that's what we mean by rare, and it goes up to a few hundred per 100,000 by the oldest age group. So for our rare outcome, we're simulating disease onset using these rates. So we have for a moderately rare outcome, we're using diabetes. We found incidence data from this National Health Interview Survey, and we basically so this was from the survey, and so we had to use some of the methods that we developed in other contexts to get incidence from rates from survey data, and you'll see what that looks like. So these these incidence rates are these dots, and then we just use smoothing to we tried 3 different smoothers. I think we ended up using the spline, which is this pink one, if you can see it. So you'll see that people are so it is increasing. Incidence rate is increasing with age, and so people are picking up diabetes. But we're going to simulate data exactly from this model, so that it does sort of flatten out, level off towards the end there. And so we're just going to generate data for our moderately rare outcome using this rate. And then for our common outcome, we're using arthritis, and we're getting that from incidence from NHANES. So same idea. We have, you'll see that the incidence tends to increase with age, but how much it's increasing with age varies with age. So we wanted to sort of make this as realistic as possible. So this is our third outcome that we're looking at. So we see the incidence increasing over time, but the rate varies with age, and then so we definitely want to look at bias at different age ranges to see when it matters. And as far as exposure goes, we're basically going to do the same thing, but rather than go into the literature and try and find out incidence of drugs, we're just going to use the same 3 curves. So you could think of rare drugs as antiarrhythmic or whatever, but that's I'm just putting a name to it. But really, we're going to have rare drugs, moderately rare drugs, and common drugs, and we're actually going to simulate, from these same curves in that case, but independently. So exposure is being generated independent from outcomes. But we're looking at these. We're imagining some that are rare, some that are common, and so on. Okay, and then so then what we're reporting is all we're doing then is we end up with looking at the bias. So for now we're strictly looking at bias, and you could think of it as asymptotic bias. And it's always going to result in overestimation of the odds ratio. In this case, in all of these cases, because you're picking up both things, as I mentioned. So what we're going to report then is percentage bias in each of these scenarios and for each age range. So I'll just show you some of the results. So this is an example where, let's say we have the rare outcome and we have a moderate exposure, and these are the age ranges. And then here, these are the control windows. So we range from 1 month to 1 year. And so, as an example, just to be clear, what we're talking about here, these are actually percentages. So this 0.9 is 0.9% bias. So that's not something we're probably very worried about. By the time you get up to 1 year, we're talking about 13% bias. So, for example, your odds ratio would be 1.13 rather than 1. Okay, so that might be something, well, I'm sure that is something you would be concerned about. So what we see is we're not seeing as, big change, and for most cases we're not seeing large changes with age, although there's a slight downward trend here for this particular outcome. But we do see by the time we're talking about a year, if you had a control window of a year, we're seeing the kind of bias that you would definitely be concerned about. In 6 months, it's still a little iffy. Like that might be more than you'll be happy with. So based on that, it seems like, a 3-month or less window would be pretty reasonable, and we'll see this pretty consistently across these different cases. So we have moderate outcome, rare exposure. Again, we're seeing you can sort of get up to in the neighborhood of 10% bias once you get out to the 1-year mark, and we have rare outcome, common exposure, and you'll just see that we're getting the same basic story in all these different cases where at 6 months you're getting somewhere around 5% bias, and a year you can be pushing up to 10% bias in these different cases. So yeah, same story for all these different things. So I'll just finish up with basically. So we're based on that, we would be recommending, at the 6 months or less, probably more like 3 months or less for these windows of time. But even a small amount of bias could affect type 1 error rates, especially. And so we're looking at finite samples, what the impact would be, but that I'm not presenting here. And then I also wanted to mention some other designs because an alternative. Well, there's a few things you could do. There's you could sort of adjust for. You could just if you know whatever disease you're looking at, you sort of know what the incidence rate is. You could probably do some kind of an adjustment, but there's some more direct ways of doing it. There's this case time control design, which can solve a time trend problem, but also can introduce bias. So this was discussed by Greenland in '97 and so on, like what the sort of issues with that are. There's also self-controlled case series, and more recently there was a case time control design was proposed where controls are from basically restricted to future cases. And so I think that seems promising. So we're currently looking at other designs and seeing and looking at trade-offs and seeing whether that solves some of these problems. But so I guess I'll end there.
I'll invite the other three speakers to come and sit up here in the panel. And for those who have questions, why don't you go to the mic and identify yourself.
Is this one working here? Yeah.
Okay, good.
You have a question for Dr. Walker? Can you hear me? Oh, sorry. 911, Columbia University and the New York State Psychiatry Institute. That was a very elegant presentation. Thank you. I thought it might be useful to relate the discussion. Talk about, the role of the provider in this kind of multi-level studies where patients are nested within providers and providers are nested, maybe in larger care systems. With, I think, some of the related discussions in the disparity literature where, in some studies, it's potentially possible to find that the quality of the care patients receive by patients of different minority status received within the same care setting might be similar. So on the individual level, there's no disparity, but at the site level, the quality of the site that the minority patients or high minority neighborhoods might be difference. So in a sense, in that situation, there are two kinds of exposures. One is exposure to disparity at the individual level, another is exposure to disparity at the system level, where the neighborhoods might be served by different quality care providers. So in that situation, maybe the potential difference when you do or do not control for provider might not necessarily in that situation be a reflection of a confounding problem, but it might be really answering two different questions related to two different exposures.
Yes, thank you. That's an important point. What you're talking about is a situation in which different providers are expressions of access to care, quality of care, by virtue of the institution they work in, and so they're mediating another effect. And if you match on that, then of course you're going to lose the effect you want to study. And so I completely agree with you.
Maybe I can clarify. There are really two different effects.
No, I understand. And I think that the provider mediates the effect that you want to study, and when you match on provider, you're matching on an intermediate variable, and you can't study it anymore.
Alan Ellis from UNC. A couple questions. First is for Chris Schmidt about the trauma centers. I'm wondering if you gave any consideration to types of trauma that are more or less preventable. I mean, some are more. Some are more preventable than others. So if there's any consideration given to that, and also to areas where there's more trauma versus areas where there's less trauma. Oh, I'm sorry, I got the wrong speaker. So in urban areas, for example, might have more trauma due to gunshot violence or to car crashes or things like that. But those are also more preventable. How do you address those issues?
So the model is. So when you're talking about prevention, I think you're talking about primary prevention, and we have a whole other branch of study that deals with that. This is what I showed you is really dealing with medical care of trauma once it has occurred, so not preventing it outright. In terms of higher prevalence of trauma in certain areas, the models are completely designed to account for that. So the goal is, the spatial profile of trauma, where it occurs in a state or across the United States, is fully accounted for in the models. And, of course, there will be large peaks in cities, and there will be much less trauma in rural areas. So the model accounts for that, but in a sense, we are working on, and we have a couple of studies that have been published looking at the matching of that level of demand, that supply, that level of demand, and the supply of the trauma centers, and the amount of capacity that each of the trauma centers has, in terms of the beds, or more importantly, the critical care beds that the centers have to account for the demand. So instead of, in that case, the models are going into, in a sense, not simply the facility, but the beds. There's more of a metric and more variation per center. But of course, that's introducing a great deal more complexity to these models, and we're working on it. So
thanks.
That's a great question.
The other question really is for Chris Schmidt, and it's about the network analysis, meta-analysis. In deciding whether the direct comparisons or the indirect comparisons are consistent with have consistent findings, it seems like it would be important to look at practical significance or clinical significance as opposed to just statistical significance. I'm wondering if there are guidelines about that, or if you have thoughts about that issue.
Yeah, no, that's a good point. I mean, this area is very new, and it's undeveloped. And one of the things, actually, in terms of writing a paper for the supplement, one of the ideas I had is just to kind of put out all the different issues that need to be considered. And it's funny because when I was listening to the talk on the trauma, I was thinking, well, we could sort of use the same idea to figure out where's the right place to put the next study. If you could come up with some, I mean, with trauma centers, there's sort of a nice geography already there, right? You've got roads and you've got swamps and whatever, but how do we do that in terms of studies? And I think there's a whole series of questions there about kind of what's the right place to put the study, and then what's the right metric to measure that on? Is it as you say, statistical significance? Is it clinical significance? And that could vary depending on what the what the question is, what the comparison is, or what the treatment the effect modifiers are going to be as well. Because you can think of in some circumstances an effect might be big, and in other cases it might be smaller, but it might be of more importance, even though it's a smaller effect because it has a more important cost effect.
Darryl Gray from AHRQ was interested in terms of the trauma analysis, the degree to which you were modeling time as a function of traffic or road conditions or things like that, because obviously I guess Bruce Goodman and people at Dartmouth have developed some software for being able to convert distance into actual time as a function of those conditions. I also don't know whether it's a further level of complexity looking at seasonality and the degree to which, depending on the season of year, in some states that's actually going to have more of an impact on travel time than it would in other places.
So the answer is we have two modes of transportation. So again, I was saying we were working in distance because we're geographers, but all that distance is converted into time. There's a lot of studies that we've done, a couple of meta-analyses, to figure out what are the time constraints on average for the U.S. for various types of ambulances. So for instance, all the models I showed you incorporate how much time a ground ambulance crew, an ambulance that drives around, takes on scene with a severely injured trauma patient versus how much time a flight crew, when they land on a scene, takes with patients. So those sorts of, and the warm-up times of the ambulances and all that's incorporated into as well. But I think the times you're talking about are the transport times. And so the transport times for the helicopters, it turns out, are pretty easy. I mean, they're straight lines, right? There's no congestion in the air for the most part. There are some landing zone issues in terms of finding a landing zone, but we've incorporated that into it. So the real challenge is the driving time. And I don't know what the folks at Dartmouth have done, but there isn't a whole lot that's nationally available that accounts for congestion. We use the standard shortest path algorithms that essentially were developed in the 70s. And these are the same ones if you put your GPS in your car, and it'll tell you the fastest way to go from point A to point B given the road network that's before you. Thus far, we don't have good national, timely data on congestion for every road in the United States. We've been working with a couple of commercial providers to try to get that so that we can bring it to bear. But right now, our driving calculations assume, as do anyone who's doing this really at this point, assume that you pick someone up at point A in the U.S., flying at the speed limit of that road. They get picked up. There's no stopping along the way, and then you drop them off. And in fact, we've done some, and other people have done it too. It's not that far off from the congestion parameters internal. Now, there are seasonal congestion parameters. There are daily congestion parameters that also need to be brought to bear in all this, and we haven't found a way to incorporate those in. I'll say that probably a good way to do it is to leave the deterministic optimization world and begin to have more of a stochastic approach to this in terms of what are those parameters and when do they typically happen. But thanks for that question. It's a really important question.
Do we have any more questions?
I have a question for Chris, and I was thinking of the 5 ways of thinking about similarity, and I was actually very concerned by the last one, which was that all the patients could have equally participated in any of the trials. And I see how that generates similarity, but I'm concerned that if you use it as a criterion for similarity, that it leads you to throw out almost everything, and it could be used by critics of your method as saying, well, they brought in a lot of stuff that they really shouldn't have put together.
Yeah, no, this is really it's sort of a proposal, and I'm not sure that, I sort of have to work out the mathematics as to whether, it's really required, and whether they're sort of mathematically equivalent. I think it's sort of one heuristic way of thinking about it, and this is, again, when the main message I was trying to get across is that these new techniques seem very good, and it seems like a great, oh yeah, let's put everything together in one network, but you really have to think hard about whether that network is valid, and that's one of the considerations. And I agree that you don't want to have to throw everything out, but on the other hand, I do think you have to think about whether if one trial doesn't include a couple of arms, or in the example I gave where there were 12 different treatments, you're not going to have a 12-arm study. So does it really make sense to have those treatments all together in the same trial?
Also, it seems to me that this is an area where random effects models would be useful, and that sort of the assumption that your information is getting better and better as you get more studies doesn't really allow for the fact that they could be somewhat contradictory to one another.
Mm-hmm. Yeah, and I mean, I didn't really bring up Chris sort of mentioned I tend to do Bayesian analyses, and I didn't really want to get into that discussion, but I think prior information here is something you might be able to make use of.
Yeah.
So.
Thanks. Any more final questions? I think we're coming up near our break time, so I want to thank the speakers for great talks.
We will continue at 10 to 11 sharp.